Looking at the evidence for different methods of pelvic floor muscle training, it is level A evidence that pelvic floor muscle training alone is effective to treat stress urinary incontinence. And if you add resistant devices, vaginal cones, and biofeedback, there is no additional effect of that. And the last Cochrane review in this area also confirmed this, because they say that, well, there seems to be more effect if you have biofeedback, but these studies are really flawed by the fact that the dosage is much higher and there is much more supervision in the biofeedback groups. So again, that's really add to what I already said, more is better than less. It's not the biofeedback, but it's that you are doing more, so the dosage is higher. Electrical stimulation, we do not know the effect of electrical stimulation for the moment, and it's sort of fading away, I think, for stress urinary incontinence, and there doesn't seem to be any additional effect of combining any of these methods, which is a bit strange. However, if you have a method that is really good, like peripheral muscle training, it's really hard to show that something is better, because you need a huge sample size to do that. So maybe 1,000 in each of the arms to prove that, since peripheral muscle training alone is really effective. So this is a study that we published in the British Medical Journal in 1999, showing the difference in outcome between the control group, the pelvic floor muscle exercise group, electrical stimulation, and the cone group. And you can see that all of them had actually a reduction, but the reduction in stress pad test was only significant compared to the control group in the pelvic floor muscle training group. And this is effect size, and this is why we're doing randomized control trials, because we know that there may be changes also in the control group, so we are looking at the difference. And the only method that was effective was pelvic floor muscle training. So how come, when we have all these fantastic reviews and Cochrane, and we have the systematic evaluation of this area, that there are so much interest in alternative methods? Why are we not satisfied and trying to work on pelvic floor muscle training? Because we know that this will work for the patients. Still, these questions comes up. There has been some suggestions in the literature that this model for pelvic floor muscle training is more effective. It was proposed from the Sapsford group in Brisbane, and quoting, saying that abdominal muscle training to rehabilitate the pelvic floor muscles may be useful in treating urinary and fecal incontinence. Another quote, the findings of a small experimental study indicates that exercise of the abdominal muscles may be beneficial in maintaining pelvic floor muscle coordination, support, endurance, and strength. After that, we have had 2 ultrasound studies, one from Mark Sherburne's group here, when I was here last time in 2001, and one from our group in Norway, showing that actually transverse abdominal training may push down and open up the levator hiatus. However, what we need is randomized controlled trials to look at this. And this is a study from Chantal Dumoulin in Montreal, looking at pelvic floor muscle training versus pelvic floor muscle training plus transverse abdominal training. This was a single-blind randomized controlled trial. They were done at least 3 months postpartum. The intervention was 8 weeks, and it was once a week with a physical therapist and then 5 days a week at home. The patients were randomized to 3 groups. Group A was pelvic floor muscle training plus electrical stimulation. Group B was the same as Group A plus transverse abdominal training. And then the fantastic with this study is the control group, because they had massage, which is so elegant, because, I mean, a lot of people say, well, everyone gets better if they go to a physiotherapist because you're so nice to the patient, so it's just the attention, it's nothing to do with the peripheral muscle training. So here they really had a lot of attention in that group, which was excellent, I think. The results show that there was a 70% cure rate in both of the treatment groups, and there was no cure in the massage groups. They still were incontinent, but they improved the quality of life. Just telling that we can't just look at quality of life, I think we need to look at the leakage and the problems. However, the main finding here is that there was no additional effect of adding transverse abdominal training to pelvic floor muscle training. After that, the group that proposed this method has also conducted a randomized control trial published by Hung in 2010 in Manual Therapy. This was a single-blind randomized controlled trial, and the patients had a history of stress urinary incontinence or mixed urinary incontinence. This was a 4-month intervention, and I just put this with red so you will remember this, because you will see in the conclusion that we need this information, because they all followed vaginal palpation before starting the study. The alternative treatment here, and this is a quote from what the authors wrote, was 8 visits with a physical therapist, and they were doing diaphragmatic breathing, tonic activation of the transverse abdominal and the pelvic floor muscles, muscle strengthening of the transverse abdominal plus the pelvic floor muscle plus the internal obliques, functional exploratory patterns like coughing, sneezing, on impact activities such as jumping and running, so that's basically the knack done in other situations. And then the pelvic floor muscle training group. And the pelvic floor muscle training group, they got oral instruction and usual information on urinary incontinence and pelvic floor muscle training and bladder hygiene. So actually using the non-effective arm in former randomized controlled trials, because we have shown that more is better than less, so this is not really supposed to be working. The results show that significantly more patients were subjectively cured or improved in the alternative group. There were no differences change in pad test, number of voids, number of leaks, pelvic floor muscle strength. And there was also a significant difference between groups at post-test in the number of activities affected and avoiding activity due to needing a toilet. There are several limitations in this study, because significantly more women had urgency in the alternative group, so that may actually explain why they improved. If you look into the table of this study, the amount of leakage and the numbers of leaks at baseline were actually 0 in both groups. So how can they improve in stress urinary incontinence if they don't have stress urinary incontinence? The alternative includes also pelvic floor muscle contractions, and the pelvic floor muscle training, as I said, program is far from optimal. And there are huge differences in dosage and attention between these 2 arms in the RCT. And then they conclude that this is promising for those who cannot accept palpation, but they were all palpated in this study. So how can you get to a conclusion like that from this study? That's really hard to find. So we have other methods as well. I don't know if you heard about the Paula method. This is done in the Middle East. The Paula method of circular muscle exercises. The theory is that there is an activity of distant sphincters that affects other muscles as well. So if you use your muscles around your mouth or your eye, that will give you a co-contraction of the pelvic floor. And you can just laugh, but it's used in these countries. I was laughing myself, but you know, it's really, yes, it's done. This was then based later on a single-blind randomized controlled trial with 59 women with stress urinary incontinence or mixed urinary incontinence. The Paula method was individual 45 minutes of weekly exercises, including, again, pelvic floor muscle training, and then daily 15 to 45 minutes at home for 12 weeks. And then comparing to what? Pelvic floor muscle training, group training, not individual training, 30 minutes weekly for 4 weeks. And daily 15 minutes at home and phoned by the physiotherapist every 2nd week. So again, the same really strange difference in dosages. So the results show that both groups were significantly reduction in pad test. There were no change in pelvic floor muscle strength in either group. And the quality of life improved only in the Paula group, which again can be explained by the more attention in this group. And again, the limitation of this study, again, was the protocol differences, the dosage and the attention between the 2 groups, and that also Paula includes pelvic floor muscle training. And there were no comparison between groups, which should be done in all randomized controlled trials. That's why we have a control group. We should look at the difference between the groups, the effect sizes. That's why we do it. And then after that, so it went in the other way. We did some experimental studies, and this was in my group first with 4D perineal ultrasound, and this was based on a power calculation. We had 17 pregnant or postpartum women, and the results showed that there was significant reduction of the levator hiatus area and muscle length only after pelvic-floor muscle contraction, nothing during the POLA. And the conclusion of our experimental study was that no facilitation of pelvic-floor muscle contraction during constriction of the mouth. At the same time, and this is interesting, a Brazilian group, they did a similar study using surface EMG, and they looked at 34 healthy nulliparous women. And the results showed, again, no activation of the pelvic-floor muscles during the POLA method, and no additional effect of adding POLA upon pelvic-floor muscle contraction. So again, concluding no activation during the POLA method. It's still used, though.